Woe is me.
Oh, shoot. That was between the water bottle.
Yeah.
Welcome back, everybody. This is Doc T. I got Dr. Westbrook over here, Dr. Dionson right here. We're just laughing because David's having a day today.
It is what it is.
It's been one of those cluster, what do they call it? Clumsy Saturdays.
Well, we have another word for it, but it's probably not appropriate.
Probably
No.
not. Yeah, at this stage in
I
our
need
career.
a buzzer here. Just the cuss button. That's all we need.
Yeah, right.
Okay, if we had an emoji, we could pop that up on the screen real quick, and that'll give you the praise. Okay, anyway, back to talk here. So we wanted to sit and kind of explain some processes, some thoughts, some ideas, share with you out there what you should expect when you hit a therapist's office, kind of just in general. Now, there's a lot of expectations you should have. A lot of times out there when you get prescribed PT or going to a chiropractor or what have you, you'll come in with the thought of it's going to be 6 to 8 weeks, it's going to be this, and that, and the other. And there's nothing wrong with the time frames and things like that. But the one baseline thing that we run into all the time, unfortunately, is when you go to a therapist's office, you should be judging them as much as you can. And the reason for that is you're looking for, is this person, do you feel confident and comfortable? This person I'm with right now is actually going to help me. And that therapist's job is to make sure that you completely understand not just what's going on with you right now, but thoroughly explain the process that they're seeing unfold in their mind so that you, the patient, can understand what to expect. The biggest letdown you can do as far as a clinician is concerned is keeping your patient kind of in the dark on what to expect, where we're going to go, what we're going to do, what the path looks like, even though some of it's unpredictable. You know, when I'm working on you, working with you, treating you, working on this tissue to release it and then strengthening this tissue so it works better, we're not positive what's going to happen, but we know we're going to be helping. It's just going to be varying degrees. So we'll dive into this part. When you go to a therapist, PT, chiro, don't care who it is, you should always have the expectation of improving each time you're there. You should have pretty set parameters on what that looks like, whether it be the consistency of pain, the level of pain, like movement pain, meaning I move my arm to here and it hurts, now I'm up here before it hurts. Any type of progression is a good progression in the right direction. But that should be the expectation, and it should be the rule, not the exception too. So if you out there have been to a therapist for a month, 4, 6, 8 weeks, 10 weeks, I have one that's 6 months in, not a change in anything, you should have left a while ago. If you're aware 2 weeks and you're still basically feeling the exact same, I mean, literally the exact same, you probably should look for another therapist. And it's not saying they're bad, but whatever is working, you two are not connecting. And I'll be honest, I've had patients where my technique and their bodies are not meshing. So I have to, as my professional responsibility, refer them to the next person. Ortho, medical doctor, PT, someplace else, where a different set of eyes, which we're very lucky in this clinic because we have chiros and PTs and massage therapists, and we have a medical doctor come by once a month. So we have these eyes that we can put on people to make sure we're not missing something. And I've even had it on where I've given it to David, or I've given it to Justin, where I was like, hey, take a look at this patient for me because here's what I see. They're not responding the way I want to. Let me reach out to you, have a look at them. Let's see what they look like to you through your eyes. In fact, we just did this with Nandi last week, I think. We have a young wrestler, 16-year-old, 15-year-old, who we were trying to assess what's going on with him, but we weren't getting, like, it wasn't like when you do orthopedic tests on somebody with a knee injury or shoulder injury or whatever, they're not 100% accurate. You're just trying to get just an idea of what's going on. So I brought Nandi, who's a physical therapist, all the way over the clinic floor, which is like 100 feet. So it's a long way you had to go. It's really a long distance. You look out the door, you're like, God, you guys are way over there. He came over, I left the room. I told him nothing except age, symptom. That was it. He goes in, does his assessment, he walks out, we land on the same page. So that tells me that we have 50 years of experience looking at this child, and we came to the right conclusion. We're on the right page. Now, did I try to treat him? No, because the conclusion was not something we can really treat per se. We need to evaluate further. We sent him out. Now he's got an MRI, and we're finding out if he has a tear in his ACL. That's what you need to do. That took one visit. First visit, here it is. This is when it happened. We see him. Another doc sees him. Done. Got an MRI. Now we know what the next case or next path is, and what we're going down. That's how it should be. It shouldn't be, let's see it 7, 8, 10 times, and we'll see kind of where we end up. So, any questions, guys?
No, I'll kind of like, I don't know, add on to that. It has to be frustrating for a patient, and I know because it kind of it happened to me with my injury, where it's like, you know what, I feel like this might be what's going on, I think this is what's going on. Like, we're professionals, and we're not perfect by any means,
No.
but we should have a level of confidence being like, based on my assessment, this is what's going on and this is how we're going to fix it.
Yes. 100%.
And so sometimes referring out can, especially early in your career, like almost like be a shot to the ego a little bit.
Yes.
Like I didn't know what was going on, so I'm going to refer it out. It's like, no, you're referring someone out because you are looking out for this patient and think it is in their best interest that they should see someone else and get another set of eyes so we can get this right as quickly as possible.
Yeah. Like the ultimate goal of our clinic, our motto is we want you better as fast as humanly possible. We're trying to work ourselves out of a job. That's literally the joke. That's what we're trying to do.
Yeah.
Because we want you to fix you and then send us your broken friends.
Yeah.
And then we'll fix them. And then their broken friends. We'll fix them. But it's not an arrogance. It's just we can do this. We know we can. But we also know the limitation.
Absolutely.
If I have a kid come in who's got a partial tear in his ACL, we have to address this differently. I need to know this because I'm not going to give him plyometric exercises or depth drops off a box. It's like, let's see how much stretchiness we can get out of this ACL. It's like we don't want to put him in a bad situation. And also with a child, find out any person you're seeing.
Yeah.
I want to know as soon as humanly possible what's going on with you entirely.
Absolutely. Especially like if you've been going to a clinic, they've been treating you, and they actually didn't do any assessments right up top.
Red flag.
It's
Big red
something to consider.
Yeah,
Consider that for sure.
And the assessment, like we actually just met this morning, went over our updated version. And it's interesting because even though we know the movements, 3 different doctor minds can sometimes see things differently. So we're trying to hone that in. The purpose of it is if we don't know what's going on, if we don't see how you move or understand movement discrepancies or neurological patterning, how in the world are we going to fix you? Right? We're talking just your pain, like, oh, my heel hurts. Okay, well, we can get through that. Heel pain, no problem. We need to figure out why your heel pain is there, and then we need to fix that. But we have to go deeper. But that expectation from the patient, it like our patients, we tell them, say, look, if something's happening, if you're leaving here the same and coming back and leaving and you're not improving, tell us. We don't want to sugarcoat this. We're not trying to say, hey, you're doing great. It's like, no, actually, you're doing the exact same thing. Nothing has changed.
Yeah.
So, yeah, and when you have patient experiences like that, especially a 15 or 14-year-old kid, like I had one, Dr. Goswami, he's our stem cell PRP guy, came in a while back. He sent me a kid who was 13, saw an ortho, came back to Dr. Goswami. Goswami sent him to me. He said, can you please just evaluate his knee? He told me nothing else. Absolutely. Mom brings kid by. Okay, we have a suspected knee injury of some kind. Instability. Didn't tell me what though. I was like, okay, so I did an evaluation on him. Both knees, I did nothing there. Okay, that's odd, but sure. And then so we go out there and we start doing some other stuff. And any pain? No, I was like, nope, nothing whatsoever. And so I was like, okay, how in the world? Okay, he wants to do surgery on what exactly? And she goes, oh, he wants to fix his ACL.
Why?
And I said, okay, let's check it out. By the end of the treatment, long story short, I have him outside doing lateral jumps on one leg, rotational jumps on one leg, and box jumps on one leg.
He was all fine?
He did great. I had him do shuttles. He's doing down, back, pivoting on that leg specifically. And I said, either this kid has got the strongest stabilizers around his hip and knee of any kid on the planet, or his ACL is fine. And so went back to Dr. Swami, gave him my assessment, and guess what? No surgery.
Nice.
Came back to playing sport, he's fine. So even an orthopedic can make mistakes. So I'm not knocking anybody. I'm just saying, go see other. If you're not getting the answer you want or something seems off, question it as a client. Go find someone.
Yep.
Yeah, get the evaluation. Find out. Like, you want to pay us $250. We're going to spend an hour with you. We're going to tell you all we find with you. We're going to show you what we find. You're going to feel what we see and understand. And we're going to provide that information for you. Now you can do whatever you want because now you have information. Right?
Absolutely.
Got the assessment. So I get passionate about this because 20 years in it drives me nuts. But anyway, any patient stories you guys have had? I mean, it's not uncommon.
Oh, for sure. I am currently working with a patient right now who had he had a pretty bad accident where he was surfing, he fell off, and the board came back and smacked him in the back of the head.
Oh.
Split his head open.
Ouch.
He had stitches, and so he went to physical therapy because he's having a lot of pain going up into the back of the head, and then he started noticing he had pain going into like the side of the face too, like, and he describes it as nerve pain. And so I do my assessment on him, and he'd been going to PT for 2 years.
Oh my.
And
That's a long time, just in case.
Yeah.
And it was in network, or actually, I'm not positive that it was in network, but he was able to bill his insurance
was involved
through
yeah.
it. Yeah, insurance was involved.
Yeah.
And for 2 years, he'd go once a week and like get a little bit of relief, and then it'd come back. A little bit of relief, come back. It never got better. It was just like, it was simple pain relief.
If I can interject real quick,
Go
one
for
of
it.
my things like how I asked and then kept going anyways. If he said no, I was going to stop. So I was laughing. I was very, very. Do you mind? I should ask and then wait for the answer.
Sure.
We'll have patients come in, and I get this all the time as well, and they'll say, I say, well, you've done anything that helped your pain, and they'll say, oh, I did this or I did that. I said, okay, it helped pain. Did it help you like overall? And they'll say, yeah. I said, well, so your pain's gone, and they say, well, no, it's still there. I'm like, well, then how did it help? And unfortunately, you get this idea in your mind of, if I take an Advil, my headache goes away, or my neck pain goes away, that, oh, I'm getting better. And it's like, well, no, it's going to come back tomorrow. The Advil is masking what's going on, but we got to get through that. Like, the pain should be going, gone, not just sedating it a little bit or feeling a little better. So, anyway, go ahead.
Yeah. So, and then what kind of, I think worry is too strong of a word, but what concerned me when he came in for his discovery visit was that he shared that the physical therapist was doing active release technique on him.
Okay.
And I was like, well, I mean, that's what we do. So, I mean, I don't want to be just the next therapist in line where I'm only treating the pain and I'm not getting them better.
Right.
Maybe they need a little bit more of something, a little extra help. He had a corticosteroid injection into the upper part of his neck, and he said that relieves the pain, but it comes back.
Of course. Yeah.
So he came to us, and he was like, I just want this pain gone. I don't want to have to think about it. I want to be able to go through my life and not have to think about it and not have to kind of baby myself around the injury. I'm like, okay, well, we do active release technique. Sorry, like
Here we go again.
Here we go again, sort of thing. But I explained to him like our process and maybe I can hit a few different muscles than what she was doing, because she was doing a lot of work with the scar and just really local. I was like, maybe I can branch out a little bit, hit different muscles, and see if we can get a different result.
And just for you out there, just so you can understand, whenever you have a trauma, hit the back of your head, slip and fall, twist your knee, it's not the location of pain that you need to focus on. It's everything around that system that got mucked up too. So when he got whacked, his head took the blunt trauma force, but all the muscles down the spine and the shoulder, everything else, they had to absorb the force.
Yep.
Which his head cracked. That's how much force there was, right? So that doesn't stay local. So I always say this with clients to be very respectful of the therapists they're seeing. Same case here. It's not that they're wrong.
Yep.
I have the advantage of knowing what they were doing that wasn't really working.
Yeah.
So I can now think outside the box bigger.
Yep.
That's just to be respectful to the therapist, because that's just how it is. Nobody's perfect. Nobody gets everything at home run at the right time, same time. But the way you process that was completely right, like accurate, how you should do it, how you should handle it. So kudos to you, but continue.
And so,
we do the same thing when we talk about cases here in general. Like if you've ever seen us accidentally grilling another doc here, it's because we've already asked other questions that they would have. But we also have fresh eyes in the back end. Same thing here. Yeah. When you're seeing a new patient that has been seen by another provider, it's just another set of fresh eyes.
Yeah.
So we have different thought processes there.
Yeah. And he's with my process, I tell the patient, like, whatever you're doing on the day-to-day that was bugging you, like, just remember how that made you feel. If there's anything else that comes up on the day-to-day during your workout, activities of daily living, any of that kind of stuff, if anything flares it up or you're not noticing the flare-up when you're doing these activities, remember that and let me know, because I want to know those things. That way I can know if we're going in the right direction or the wrong direction. And
that should take a visit or two.
100, yeah.
That is not weeks on end or months. I always say it's weeks, not months. That process should go on. Even at this point, but yes, that's the best way to word it. Yeah.
And
information.
Yeah. So, and with those, like, ADLs are improving, workouts are improving, like other things are starting to hurt, which is normal because now you're freeing up a joint or a group of muscles that are now doing something that they're not accustomed to.
Yep.
So they're going to have to, their body has to adjust for that. And as a therapist also, we have to adjust for that and make sure the right muscles are firing and the movement patterns sound and whatnot. And he has had a couple flare-ups, and we're working through that. We're kind of trial and error with that. But that's a normal progression. Like, you're going to have flare-ups, and that's normal, and that's okay. Just for like the psychological aspect of pain in general and what you're dealing with. He's been dealing with this for a long time.
2 years is a long time.
So
yeah, it's
like,
a long time.
That's, you're getting to the point where like, am I just going to be like this like forever?
Can you imagine?
Horrible.
That's depressing. Yeah, that's depressing. Yeah.
So he's doing pretty good. We settled down that flare up, and now we're back on the right track, and he's doing well.
Good. That's so good to hear.
Yeah,
That's good.
So good to hear. All right, how about you?
Yeah, all my patients are great. I'm awesome. No, I'm kidding.
Mic drop.
Never experienced that.
Never experienced. No, I'm kidding.
And I'm out. See ya.
One of the patients that I'm dealing with right now, funny enough, he's actually one of them that made me feel old, because he was he was a firefighter.
Way too young to feel
old.
old.
I'm like, I shouldn't feel old at this point, but he's a firefighter, but he happens to be younger than me now. So normally I'm thinking they're going to be older than I am, but he's younger than me. He was... What was he doing? Yeah, he was doing dumbbell cleans, and that was his first time ever doing dumbbell cleans. Hurt his right shoulder, popping, clicking, no catching, but that was his general presentation, and he was starting to worry because, he just got into the field of being a firefighter, so he didn't really want to put his career on, the back burner here.
Just real quick, I'm going to interject this one. This is my experience talking here. So the fire guys, OCFA, love you guys out there, by the way. So you guys stay well.
Send this to your friends.
Yes. Oh. Hey, they do. I love it here. It's fun. But fire, especially the first year, they go on probation. And that probation is brutal. It's everything you think. Cooking, cleaning, you're doing everything, plus your job, plus you got to learn. Can't make mistakes. Some firehouses are a little different than others, but it's this very, very... You don't say no. Yeah. That you just don't say no. So you better pray that you don't have any body parts that don't work well. So that's a background of this. And so he was probably doing something, again, not used to, never seen, never done.
Never done.
And continue,
Yeah, I forgot which part of his probation that he's in, but I still believe he is in probation. If you're watching this and I'm wrong, I'm sorry.
Congratulations.
But yeah, you're doing
great.
Made it out. But yeah, he was doing dumbbell cleans, and he just noticed he's never done that motion before. He was doing it with not the academy, but the firehouse, and it was messing him up. So he went to a provider that is approved through them, just to get his shoulder assessed and really treated. He said he went for about like 9 to 10 visits, but there was really no change.
Okay.
And in the back of my head, especially with a shoulder that moves all the time and a job that is very strenuous, we have to assess that. So in the job of firefighting, they have to throw ladders, they have to throw hoses, and they get into some weird, awkward positions.
Very. So
sometimes their arm's going to be overhead like this when they brace a ladder just to hold the ladder together, or they're pulling across, pulling it up. It's quote-unquote non-functional stuff that you can see everyday life.
Right.
Yeah. However, 9 visits is a long time for no change.
For no change. 3 visits is a long time.
Yeah.
Yeah.
I usually say, hey, that 3-4, you should know by that time. If this 100%. Is working, is it not working?
100%, yeah.
And
just, I have to say, because we sound very arrogant.
Yeah, we do.
This is not about arrogance.
No.
This is standards. So the standard of this clinic, and for all the doctors that work here, is within that 2nd to 4th visit, and that varies based on how long, like 2 years, it's going to take a little longer to get that baseline. 6 months, take a little less time to get baseline. But 2 to 4 visits, we know if you're in the right spot or not. And then from there, if you're not, time to get you out. If you are, let's go.
Yeah.
And if I can add, like, unfortunate...
No. I had to. Somebody's got to say it.
Unfortunately, like, for what we do, like rehab chiropractic, right? Unfortunately, PTs take the brunt of our grief sometimes. And to be clear, like, physical therapists, there are great physical therapists out there, and there are bad physical therapists, just as there's bad chiropractors and there's bad medical doctors, bad orthos and good orthos. Every
profession.
And we just want to be clear, we're not bashing any
profession
or anything like that.
Nope.
But unfortunately, that is what we see most often in our clinic.
Yeah.
And same thing with bad chiros.
Yeah. I mean, across the board. I mean, it's we call ourselves the bottom of the funnel docs, because usually we're at the bottom of the funnel catching what didn't work. And again, it's not that we're amazing, special, whatever. It's just that we just think and process and assess differently. And our point of view and the way we do things, it works pretty well. So we like that. With the doctor thing, I'll tell you, when I had knee surgery right before I met my wife. That's how I knew I was going to marry this woman. I'll tell that story another time. But that woman, oh, my wife, if you're watching this, I love you. Thank you so much for what you did back then. But I had knee surgery. I interviewed 6 orthopedic surgeons, 3 prominent ones in the area, to find out what it was going to be like. Because you have to find one that thinks like you. So you don't want, I'm going to share. Can you remember to hold that thought?
Yeah.
I'll tell you a quick story. I think I told the story before. I did, about the knee for patient. The ortho has to match. Yeah, she had a torn ACL when she was 12. Never got repaired. She's in her 50s now. Plays tennis now.
I don't think you told that one.
Really?
That is crazy.
No, you've mentioned that story to us, but I don't think we've had it on
shoot,
film.
this is perfect timing then. So, and I love to talk. So here we go. All right. So we have a patient come in. She was a tennis player. Is a tennis player. She was in her 40s at the time. And we're going through, and her knee was, you could tell there's arthritic. Like you can tell an arthritic knee. Not massively bad, but there's arthritis, not moving well. Probably swells up if she's on her feet all day, that kind of thing. So she comes in, and we assess the knee, very loosey-goosey. I say, what's going on there? I tore my ACL when I was 12. I said, so why is it still like this? They didn't repair it. Which still, I understand there are some cases where that doesn't have to be done.
Technically.
Yeah, what's up?
But, it's like, yeah, interesting. Okay. So I said, well, there's a knee ortho, and I was a young doc, a few years in. So I had to kind of trust, what they say. It was like the predominant knee guy of the area. And I said, okay, well, makes sense. And he works with another doc that I love, who's a shoulder guy. He's been amazing. So, okay, send her there. So we have a 42-year-old mom, active tennis player 4 or 5 days a week, has a swing coach once a week, lifts weights 3 times a week with her friend Beverly. I don't know if she's with her anymore. Beverly, see you out there. So she's active. So I'm like, all right, cool. Goes to see the ortho. Weeks later, come back and sees me. I said, all right, what happened? What did they say? They said, stop playing tennis, do yoga, and that's it. And I thought, I'm sorry, what now? Like, I don't understand. And so I literally got the report, and I thought, that's insanity. So I busted my butt because I still realize, though I can strengthen her and do other stuff with her, if we have a 42-year-old has an ACL in 30 years. Mm-hmm. You didn't get yours, but you're a strength guy. Mm-hmm. So you built strength around your knee to support it. Yeah. She has not done this for 30 years. I am not the last stop for her. We need to get this addressed first and see if there's anything we can do outside of my skill set, and then we can revisit it. So I find another ortho, which took me about 3 weeks to hunt down. Knee guy out of Huntington Beach. Sent her there. Love this guy. Came back to me. Got her what she referred to as the Ferrari of knee braces. Got the knee brace. Said, get stronger, strengthen your hips and your hamstrings, work on your core, keep playing tennis and have fun.
Boom.
Love it.
And it's not that he said what I wanted to hear. That's also true. But he said what he was supposed to say. He was telling an active woman what she needs to do to keep being active. Yeah. Also told her it's not going to be great on your knee, but this is what you can do. And so that's what she did. Yeah. She got that, came back to me. We started getting her stronger. She still comes to the clinic today. In fact, I gave her to one of our PTs because he's great with this kind of stuff. Yeah. I'm not great with it. I'm good with it, but I'm not great with it. He's great. There you go. Mm-hmm. So I took a patient who's my patient, and the first thing I did was find the best way to get her to play tennis tomorrow, not in 6 months after we do this or whatever. Then I got her there. Then we got another doctor that did great things with her. So she plays tennis, doing great. She still won't eat the way I want her to eat, but whatever.
Baby steps.
Yeah, 2 out of 3 ain't bad. I'll take that. So that's just a good example. Even in the orthopedic world, it doesn't really matter, but it's not that the doctor has to say what you want to hear as the patient. The doctor has to know who the patient is. Yeah. I can tell my patients all day long, do this, do that, eat this, eat that. If they don't want to listen, they're going to do what they want to do anyways. I can't change it, but at least I can do is tell them this is what you should be doing. Mm-hmm. And I've had to fire some patients because I'm like, I can't work with you. It's just, I'm being honest, like it's one of those things where I know I can get you better, but if you're not going to do things that are going to get you better, then you're wasting my time and your time. Yep. Don't do that. Go someplace else. I'm not your space. That's fine. But that's kind of what we're talking about. Mm-hmm. That's the kind of mindset a patient should have and then a doctor should have with that patient. Yeah. Now, I do believe the first doctor did what he thought was best for her, but that's a wrong fit. Yeah. Right. If we're going to tell you, get off your butt, go work out, eat better, and that's not a good fit for you, you just want to go for a walk and do something else, then you go find a doctor who's going to do that for you well. Yeah. Because they're really good at that part. Mm-hmm. Go do it. That's cool. Yeah, but you're going to be a lot happier, and the doctor will be happier. Yeah. Otherwise, you're going to be beating your head against the wall trying to get them to do something, and it doesn't get done.
They're not going to do it.
They're not going to do it. Yeah, and just be honest. Yeah. All right.
Yeah. I think we have told that story before. You said Ferrari of knee braces. And
see, right. I knew it came out there before, but it's such a great story because as a young doc, you're kind of like, they're an ortho. They're in a big group. They're well-known, renowned. You're like, they know more than I know. But they forget the one psychological part was that patient picked me because of the way I think, which is, what do we do here? We enable. But we do it in the most commonsensical way, and we tell them the truth. This is just how it is. You're going to break your knee down. You're probably going to need a replacement. Absolutely. But we're not going to let you stop playing tennis. That's your mind, your emotional, happy space. You need to stay there.
Yeah. Absolutely.
So back to your fire guy.
Back to the fire guy. But before we go on, we're leaving that story in. I don't care. I'm not editing this out. It's staying there.
It's a good story. Yeah.
All right. But for the fire guy, it was the whole dumbbell cleans thing that was messing up his shoulder here. Went to PT/chiro, whatever the provider was, for 9 weeks here. No change. He messaged in the group chat that he had, hey, what are spots that you guys recommend? And he stumbled across us. I happened to take him on as a patient and did our stuff, did our assessments. Noticed some popping and clicking in the shoulder, but also how he got there was a little interesting, especially when he got overhead. It wasn't the cleanest motion to get there, so at some point my brain was just checking for a labral issue because it wasn't here. It was almost forward and out, so I just wanted to make sure.
We call them road speed bumps.
So
they're lifting the arm up. I'm going to show you from this side of the camera so you can see out there. It's when the arm comes up, we're looking for the smoothness here, and they kind of go here. So they're kind of avoiding all the speed bumps to get themselves overhead. Which we're that's not good.
So that clicked off in my brain. So first thing that my brain said was, hey, has this been assessed? Is there any imaging? Is there anything that we can see right now that you have had in the past that tells us there's something wrong there? And he said no. So the first thing that I did at that point, it's already been 9 weeks treatment, you're going to Goswami just to get checked out. But in the meantime, we're also going to treat at the moment. So because we're also referring out to Dr. Goswami just for imaging, it doesn't mean treatment stops there. It just means we're modifying something at that point. We need to know what's going on. Did a couple
and just real quick about the reason why that is, let's say he's MRI, labral tear, surgical. By us treating him and taking care of some of the muscles and getting him a little stronger, we're going to make the outcome of that surgery monumentally better. Because if you go into a surgery as healthy as humanly possible, you're going to exit it way ahead of the game. Because that trauma is no joke on the shoulder. And so actually there's a guy, I think he's retired by now, he did hip replacements. But he literally said, you have to be X amount of BMI, X amount of weight, X amount this, X amount that. Here's your exercise schedule before surgery even begins. So I was I love that guy. You have to do that stuff. So good.
So I did that first. I was week 1 or 2, visit 1 or 2, where I said, hey, we should probably just get the image or get a referral, get someone else's eyes on this to understand what's going on, right? In the meantime, I was treating him. I wasn't really getting the same, faces from the ART, because you know what I mean. When
emoji faces.
When you hit something
emoji faces.
That hurts, you feel it with the ART stuff. He wasn't getting that. He's like, oh, that was okay, not bad. I was like, is that something that I'm doing wrong? Checking my technique, all this stuff, right?
Sounds like you should have got another pair of eyes on it.
Well, I got Swami's eyes on it. But I started treating, and then we did some exercises, and then I was in some ways kind of doubtful of myself just to see what was going to go on next. His schedule only permits once a week visits, so I wish I could get him another time, but firefighters, right? The next week he noticed, I have less pain going overhead and doing other things. So I was like, okay, we're on the right track. Let's keep going. I guess it was some of the exercises that I gave him too, because I took one out, and then he had a slight dip in terms of the progression of where he wanted to be, so I knew the exercises were working. Switched a couple things up, and I gave him a Turkish get-up variant of some sort, because he doesn't have the full technique to get up here. So I was like, hey, let's just roll, right? Let's
just roll.
Let's get with that. I call it an armbar type of thing.
Yeah, connect the dots. Yep. Gotcha.
That was a turning point for him, where he has much less pain now, but there's still some pain overhead. We're still working there, but there's improvement from visit 1. So that's 3-4 visits in. And that's really important there. Not saying that I was any better than the other guys, but what I'm saying is we're making the changes that are appropriate when necessary. He still got the images from Goswami here. He got an ultrasound. With what you could see on the ultrasound, there was no labral tear. But it was scarring on the rotator cuff, which makes sense.
That's why. Overhead. So just, again, clarification for people out there. The rotator cuff, which you all have heard of, but it's actually a little cartilaginous tissue that kind of holds the shoulder joint together like a little suction cup. And it's a compressive joint, meaning it runs a compression. It needs to stay compressed. You don't want to have shoulder Shoulder surgery. I think I need to know Celsius. Because once you cut that open, you decompress the joint, you can never compress it again. Bad. Secondly, when he has scarring in there, that means he must have been a pitcher, volleyball, some type of athlete where he had a constant stress to the area. So when he did a clean, which is a very shoulder intensive move if done incorrectly, and I promise you if you've never done them, he did them incorrectly. So he was expecting his labral joint to support the stress of the clean, which he couldn't. So he had to use other pieces of the shoulder and the shoulder girdle basically, and that's what he really aggravated. And that scarring, depending on where it is, because up in the top of your shoulder where most people's pain is up in here, there's not a lot of space.
No.
So if you build some scarring in there, it's not, you're taking space away, which means things are going to have to work a little differently. So that's very fascinating, actually.
When we talk about orthos on that one, I didn't really, bring them up other than like a couple tests here and there in terms of range of motion. I also did the empty can test, basically this test right here, to check the supraspinatus.
It's very embarrassing when you forget what you're testing.
Well, I did.
I'm just kidding.
I didn't want to get
I'm
specific.
I'm just kidding.
I almost had just tested. I almost said rotator cuff. That would have been bad. Never say that. Well, I was testing the supraspinatus there, just really checking the integrity of it.
Of course,
Going overhead, I wanted to make sure everything was good.
Smart.
There was pain there, which makes sense with everything that Dr.
It starts to line up, it starts to line up.
So, funny enough, when we talk about sending someone to someone else, right, you're always scared about, quote unquote, losing a patient, right, or stopping care. Swami said, no, go back, do PT or chiro, whatever you wanted to call it there, for another like 4 to 6 weeks, and then we'll reconvene.
That's fantastic.
Yeah.
It's what is it? We joke in here a lot. We like to tease each other because nobody is always on as far as remembering things, and we try to tell stories and whatever. It's very funny, but you can tell the genuineness, like you know what you're looking for, what we're doing. And the beauty is when you do the assessments and do the testing and do the referrals, make sure you're covering all your bases. You get a line of thinking, right? So this doesn't make sense. This doesn't get this done. Oh, now that makes sense.
Yeah.
This is where we're just talking about the whole point of this topic. If your clinician is not connecting dots, then you're in the wrong place. Yeah. Not because they're wrong or they're flawed. It's just something's not connecting, so you need to go figure out what that is. And you just figured it out. Now, he may be a PRP or stem cell. He may be a Prolo shot. He may be something else. Yeah. But you guys have more answers in 2 weeks than he got in how many? 9?
9 visits. I don't know how long 9 visits was, but...
That's fantastic. And that's really, as patients go, that's really what they want. They just want to be told, what is it? What can I do? How do I fix it? The simplest, fastest way possible. Yeah.
So we're still working through it, but
that's fantastic. Yeah, that's fantastic. And we'll talk about that case on side. Discuss a few things too. That's where 20 years experience gets to help you out a little bit. Yeah, some things maybe just different eyes. That's great. That makes me really happy, actually. Yeah, love that. Okay, so basically, bottom line, if you're going to go see a doc, ortho, rehab, whatever it is, you really should go in with an expectation of, I expect to get some answers. Now, mind you, there is some gray area stuff. I've always gotten patients. I have one right now, a young lady who's, she could have 19 different things. The only thing I'm certain of is what's aggravating it. The only thing I'm certain of is what's helped it. And from there, it's kind of like now we're kind of checking things out. And it's a very tricky gray area case. And we're trying to avoid surgery at all costs. Yeah. And there's one ortho I work with, I won't say this out loud name-wise, but his response was, and I love this, I love truth. There's nothing wrong with it. Like, so what we do is not a perfect science. No. Orthopedic, PT, chiropractic, massage, I don't care where you go, dentistry. Nothing's perfect, but we do our best. And this ortho said, we don't want to do this to you because by me trying this surgery, I'm kind of guessing a little bit on what the parameters look like. And if you're guessing, nobody wants to do that. No. I don't want to send you home with a guess. Like that can go any which way we will lose. That's a movie from the 70s. Love it. So Clint Eastwood, love you. But it's one of those things that just, if you got an ortho saying that, he's like, look, go try everything else. You know what I mean? And just to bring out this case, she went to PT for 6 months.
No change?
6 months, not one iota. And it kind of broke my heart. I feel bad for the family and the parents and the kid, of course. But this poor person is 2 years in, 0 change. Had a smile on her face this morning. She had 24 hours of just no pain. Didn't have to take anything. And she was, unfortunately, she's very unstable in the shoulder girdle. So, and she's her sport is in the water.
Water polo.
No, don't say that. Could be surfing. But it's basically repetitive motions. And she has a shoulder girdle that doesn't work well, which probably worst sport you can match up with a bad shoulder girdle is surfing or water polo or swimming, anything like that. But I had to break the news that we have to pull the plug on that for a couple weeks because we have to take away aggravants. If we don't do that, we're never going to figure out what's really going on with her. So that's one of those sad conversations you have. But by my mind, in my estimation, this is about the best thing to do because it hasn't been done yet. So in 2 years, if it ain't broke, don't fix it. Well, if it's broke, fix it.
Yeah.
It's broke. 2 years. Fix it. That's what we're doing now.
Yeah.
So there are hard times too. It's not easy to do what we do sometimes. I've lost more patients that I can count on my hands because I told them you're going to have to stop your sport. Not exercise, not movement, but your sport, because your sport is specifically causing the problem. You got a runner with Achilles tendonitis. They can't keep running. It's going to snap. It's just a matter of time. But what do we do here?
Enable.
Oh, yes. There are so many other things, like burpees, that you can do. Just kidding. Not burpees with Achilles. But yes, you know what I'm saying. But you can give other exercises to do on a rowing machine, riding a bike, anything upper body, swimming, anything to kind of help keep them going. So for her, I have her doing BFR, right? I don't know if it's going to help. I told her point blank, I'm not sure because this is usually with injured tissue. I don't see an injury in her. She's had more imaging than anybody under the age of 50 should have, and they couldn't find a thing. So I said, this will at least make you healthier and help you recover a little. Let's give it a try. Gave her some exercises because I want to keep her in athletic shape so that she doesn't lose anything. And then, this is the first time now I think that I'm aware of, no, shoot, damn it. Oh, darn it. Edit that.
Cuss button. When I was done, I was sorry. Cuss button right here.
She's the second one, unfortunately. Oh, bummer. But she's the first, not water polo player, that has done this. She's going to egg beat her in the pool for about a half an hour, I think, fingers crossed, with BFR on. Because our group that we use, Be Strong, props to you guys, it's actually waterproof, so we can actually do it in the water. I've had one triathlete swim with it on, and she said it was the worst.
That sounds horrible.
Oh my God.
I mean, I've done some dumb stuff with BFR. Just when you say go out and play, what if
Play.
I bench with BFR?
Oh,
the 30,
that's
20, 10? I'm like, no, what would I do?
Yeah. So anyway, we're stay tuned. We'll bring this up again in a couple weeks and kind of touch base on some of these cases, just because it's fun to touch base and see where they are.
Yeah.
But this is one where I had to stretch my imagination to leaps and bounds. Like I gave her a wall plank, which we're familiar with, basically lean on a wall, you're a little bit of an angle. And that within 6 seconds was shaking. Like everything was just unstable. And so you look at that and you're like, okay, so her rules are different than every other patient.
Yeah.
Now, if I didn't assess her and look at her, and I think I'm on visit 3 with her, maybe 4, we've pivoted 5 times. I mean, even in a text, I pivoted again. And so we're basically trying to figure out how we get this young lady to stabilize herself so that her neck isn't driving her nuts and she can sleep at night. So... yeah, some of these cases are very tricky. They might take a little longer than we expect. But just so you know, she's not coming back in for another week. And then after that, I'll see her again probably a week, maybe 2, because we need BFR to do its thing. And that takes a couple weeks to do. She doesn't need to see me to do that. So that's where we're like, if you're seeing them, 7, 8, 9, 10 weeks in a row, 2-3 times a week, and things aren't changing, that's bad. Just a bad dress. So I beat that dead horse, I'm sure.
100%. Yeah, when you talk about that, we also... kind of take into consideration we really take into consideration the natural history of any healing, right? Yeah. So 2 years for your patient there, that's way too long for any tissue healing in general. Yeah. Whether that's, we're talking about an ankle, a neck, a knee, elbow, that shouldn't take 2 years to heal. So
especially when you're getting treated.
Yeah. If your clinician really takes that into account too, you can kind of weed away what's a good treatment, what's a bad treatment. Is this a good plan? Is this not a good plan? Because even like for me, I deal in the world of like powerlifting all the time. We're always lifting hurt. That's how it's gonna be.
Something hurts
by choice.
Yeah, something hurts, not necessarily injured. Though. There's a difference, right?
Yeah.
Sometimes injured. Yeah.
Sometimes they're together. Right?
Yeah.
Knuckleheads.
Yeah. 100%. Do they still lift? Yes. Like one of my patients right now, I'm pretty sure he has a disc issue because he said cough, sneeze.
Yeah.
Kind of hurts.
Yeah. Flagship.
But we're doing great in his rehab, right? He doesn't want to stop lifting. We just had to figure out what works and what doesn't work for him.
Also, I got the new machine coming.
Oh yeah, that's gonna be fun.
The Nordics.
We're gonna have to film that.
I was like, that's gonna be so much. We got a new machine out there for everybody out there who loves Nordic curls. You need to come in. But we have an entourage of back fixing toys. I am so excited for that thing. But anyway, continue. Sorry, you got me excited thinking about it. I'm like, I can't wait.
Yeah, but with that being said, like we talk about how long a disc could take. We've seen everything from 2-3 weeks. I've seen something that's 6 months. You've seen some weird, funky stuff too. But we have to take that natural history into account when we're dealing with the injury too. And if you don't hear anything about that in your visit, you should probably consider something.
So I'll give you a good example. You have some?
No.
Okay, I'll give you an example
go
for you.
for it.
So again, years ago, I was in a one-room office. I had a patient come in who I've treated. She was a triathlete, so shoulder, knee, ankle, hip, ear, toe. Pick a body part. She's messed it up somehow.
Yes.
It's just
circles
like
the whole body on the
it's
intake
just, I've
form.
had that before, right? You're like, your whole thing. Okay, can you narrow that down to one thing right now? So she came in and threw her back out. Now, I had mine done. I blew my disc out, and 4 days later, I was having surgery. Mm-hmm. That was a very serious, like I say, my motto is like, I don't have a motto. What I say is bad things present badly. Mm-hmm. The worst low back pain you can have, or the worst injury, if you will, is the one that's not surgical, but it's still disc related. Mm-hmm. You're hunched over and all antalgic and can barely move, because that literally could take 6 to 8 months. Mm-hmm. It just depends on what your body did, which no MRI is going to show you, no clinical testing is going to show you, no assessment is going to show you. We don't know. Mm-hmm. It's just, it's a cluster in there. Mm-hmm. So we're going to hope best. So this is the other thing with your clinicians. I was young. I still have to make money to pay bills and support my family and so forth. But I looked at her and I said, you're a cash patient with me because I don't do insurance. Mm-hmm. You're cash. You're going to want to go to a PT. You text me and I'll text you what to say and what to do to make sure they're on the right path, because your insurance will cover that. And I told her point blank, this is going to be a few months. The way everything looks on you, and just having dealt with it myself and dealt with other patients, go do that. Mm-hmm. When you're upright and moving, give me a call. When you're ready to get back into tries, give me a call. Because I know where my place is in her world. But for her, she has to come in twice, maybe 3 times a week.
Especially when it's that acute.
Yeah, palliative care. I mean, literally teaching how to walk again. And I thought to myself, you know what? If I can text her and keep in contact and help her, because sometimes, and I mean it this way, not that the PT wouldn't know what to do, but if the PT hears certain words, or any therapist actually, chiropractor, doesn't matter who it is. If I hear these words, I'm going to go down that path. If I hear these words, I'm going to go down that path. But the patient doesn't understand that. So the patient can sometimes walk in saying like, I got a 10 out of 10 in pain and dying. And I'm like, we need to call 911 then. Yep. They're like, well, it's not that bad. I'm like, okay, then what do you mean?
It's not 10 out of 10.
I'm like, we need to figure this out, right? So sometimes the semantics will get in the way. Mm-hmm. And so I try to clean that up by saying, tell them this, this, and this. Word it this way, and that'll guide your care. 6.5 months later, she calls me. Mm-hmm. Comes back in. She's upright. Still has a little stiffness in the morning, stuff like that. But we got her back on track and fixed her right up. Mm-hmm. But she gave me a hug and thanked me because I saved her thousands of dollars. And it wasn't like, it was no big deal because I knew the situation. Mm-hmm. And I was very fair with her. And for me, it was like, I'm building relationships with you. I want them to know I'm honest, I'm ethical, and I care about them. Mm-hmm. That's what I was after there. I said, I can do the same thing, but doesn't make sense. No. Yeah, mm-hmm. Doesn't make sense. And sometimes I have cases like that with knees, post-op for sure.
Post-op's always funky.
Go to the PT.
Yeah. Mm-hmm.
That's literally what they're trained to do better than most, maybe athletic trainers. Their post-op stuff. We can do it, but that's not our forte.
You go to Alvin, go to Nandi.
Yeah,
we just talked about
go to Alvin and Nandi. Yeah,
they're right there.
They're 100 feet away.
I know it's a long distance.
It feels like it's. I've walked over this sometimes. I'm like,
I'm out of breath.
I'm back to 20. But that's what you're after. You're trying to find, like, as clinicians go, that's how we're looking at our patients. Mm-hmm. We're really determining, like, right fit, of course. Right fit also, can we help them?
Yeah.
And that's it. And if we can, great. If we can't, then we're going to find the best place for you. So that's truly our mission statement here.
Mm-hmm. Yeah,
kind of
absolutely.
Thing.
Yeah, wonderfully said.
Thank you.
That was great.
Well, shoot, that might be a parting gift right there. That might be the way to do it. Yeah. That might be our best. I'm not going to ruin it. Okay, so.
Well, cuss button.
I'm a ruiner. But that's really all we say. So from the team at SHARC, PT, Chiro, Massage, the whole group, it's really take that time as a patient. You should be interviewing that doctor. I know it's tricky out there financially sometimes when you get the in-network, out-of-network conundrum. It can be challenging. I understand that completely. If you're not confident in your doctor, though, or if you're not confident in the path you're in, don't question yourself. There's a reason.
Yeah.
If there's some information you need or something's not being relayed to you, you should voice that. Mm-hmm. And all my patients, sometimes to my dismay, as in like left the clinic in their car, get back out of their car, come back in the clinic because something popped up. And I'm like, no problem. That's what we're here for. And I'd rather she did that than went home and 3 or 4 days later I see her and this like literally on the way home it happened. I'm like, well, like I've told patients, turn your car around, come back. Just don't go home like that. We got to make sure you're improving and everything's where it's supposed to be. So, all right, on that note, that was a lot.
Yeah.
Anything else to add, guys?
In terms of this topic, no. But if you want to see Alvin, because we've mentioned Alvin twice already in the podcast,
Alvin,
leave a comment below.
Please.
Saying we want Alvin.
You're going to find out about Nandi, who's amazing, fantastic. We actually got him to tear up almost, so that was pretty cool.
Oh yeah,
it's always you guys.
We love a passionate guest.
Yep.
Yeah, 20 years from now, when you guys are doing something like this, and somebody asks you that, and you reminisce these moments, you're gonna be like, tear. Yeah, it's just something, man. It's a big deal. So anyway, check out those podcasts. Of course, we'll get Alvin in here one way, shape, or form or another. Well, we're out.
And we're out.
See you guys next time. This is Doc T.
Dr. David.
Dr. J.
Bye, guys.